Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Today we have a topic of role of occlusion and temporomandibular dysfunction disorders in periodontal disease management. This is one of the topics which is related with occlusion and the periodontal disease. Okay. I hope this will be a very simple topic for you, inshallah, because this is among the series of topics where you have already studied. It is from your Karanza, the chapter number 35 of your new Karanza, 14th edition. Okay, what I have done is I have tried to simplify this as much as possible so that it is simple for you. I put up things which are very simple, try to make it to simplify the thing and to make you understand what is occlusion, why occlusion is important, what is the significance of an ideal occlusion. These are things that are very common questions that come up in our mind. Okay, there are some dentists, some doctors, some dentists who are very much possessed with occlusion. What they think is, if you have a backache, they think maybe it has something to do with occlusion. If you have pain in your knee, they think it has to do with occlusion. And there are some dentists who just do not like or do not understand occlusion, and so they do not try to balance the occlusion when they do restorations and other treatments. So what we want is, we want a balanced view of occlusion. It's not that you start thinking that every problem in the body is because of occlusion, and it should not be that you just ignore occlusion. Okay. I hope that you understand this very clearly. Okay. The masticatory system, if you look at the masticatory system, it consists of various parts. The enamel, the dentin, the pulp that make the teeth. Then you have the periodontium, which is made up of the gingiva, the bone, the periodontal ligament, the alveolar bone, the cementum. These things joined together, put together, make up the periodontium. Two soft tissues, two hard tissues. The cementum and the alveolar bone, the two hard tissues, the gingiva and the periodontal ligament, the two soft tissues. Okay. Then you have the articulatory system, the temporomandibular joint, the muscles, the occlusion. All these together make up your masticatory system. What is occlusion? Occlusion is basically the contact between teeth. Occlusion is basically the contact between teeth. When you open and close your teeth, you have contact, and that makes up the occlusion. Now we'll go fast through some of the definitions that we study with occlusion. These definitions come up with all the textbooks, or you will read these definitions in prosto, in restorative, in perio. All of these these subjects will make you refresh these definitions, because these definitions are very important for us to understand occlusion. What is centric occlusion? It can be described as occlusion that the patient makes when they fit their teeth together in maximum intercuspation. When you close your teeth, when you go for an habitual bite, when you close your teeth, the maximum fit of the teeth together is what makes the centric occlusion. Is it clear? I hope that you understand this. See, it can also be called as intercuspation position, or ICP, or bite of convenience, or habitual bite. These are all synonyms. That is, they are different names for the same centric occlusion. Okay. Then you have what is called a centric relation. Centric relation is not an occlusion at all. The centric relation is actually a jaw relationship. It has nothing to do with the teeth. That is, it is the only centric that is reproducible with or without teeth. Even when the teeth are not present, for example, in an edentulous patient who doesn't have any remaining dentition, still you have a relationship between the maxilla and the mandible, and that relationship is called as centric relation. That relation is what is called as centric relation. Okay. Then what is the significance of this centric relation? See, there is this relation, that is the relation between the maxilla and the mandible. The mandible relative to the maxilla. See, maxilla doesn't move, the mandible moves. So the relation that is mandible relative to the maxilla is a reproducible position. It is a reproducible position. So all the dentists like this position, that is the centric relationship, because there can be an agreement between two. For example, I am a dentist A, you are a dentist B, and another student is dentist C and dentist D. We all can reproduce this into certain level. So we have an agreement. Things that cannot be reproduced, it is difficult to have an agreement, right? So these are reproducible. This is a reproducible position. That is, you can reproduce it. So patients with no teeth still have centric relation. Even when the occlusion is not present, the teeth are not in contact, extracted, still you have occlusion. Okay. Then we go on to freedom in centric occlusion or long centric occlusion. Okay. You close your teeth. Imagine you close your teeth. Freedom in centric occlusion occurs when the mandible is able to move anteriorly for a short distance in the same horizontal plane, which while maintaining tooth contact. Now imagine yourself, you close your mouth slightly, touch your teeth, and try to move this mandible. And when you are closing this teeth, there is some anterior movement for a short distance, and this is the freedom in centric occlusion. Okay. If the front teeth, you will not have freedom in centric occlusion if either the front teeth or the posterior teeth do not allow this movement in the horizontal direction. Okay, for example, imagine if a patient has a single supra-erupted tooth. For example, 1/6 is missing, you have the other opposite side, first molar, which has supra-erupted. Can you imagine having this freedom in centric occlusion? It's difficult. Okay, in class 2 angles, class 2 division 2 incisor relationship, or when you have an incisor with a huge palatal restoration, you cannot have this freedom in centric occlusion. So this will lock the whole mandible and the maxilla in position. If you do not have freedom in centric occlusion, what will have freedom in if you do not have freedom in centric occlusion, or if your long centric occlusion is not proper, what will happen is the whole maxilla and the mandible during the bite will be locked. Okay. Then we go on to something what is called as dynamic occlusion. It refers to the occlusal contacts that are made while the mandible is moving relative to the maxilla. When the mandible is moving relative to the maxilla. See, it depends on two things. One is the posterior guidance, and second one is the anterior guidance. What is the posterior guidance of the temporomandibular joint? What guides it? The mandible. The thing that guides the mandible posteriorly is the temporomandibular joint. Your mandible cannot move beyond, yani posterior to the temporomandibular joint. Okay, so the posterior guidance to the system is provided by the temporomandibular joints. What the anterior guidance is provided by the teeth that are touching in the protrusive or the lateral movement of the mandible. The teeth that are touching in these movements, eccentric movements, is provided, the anterior guidance is provided by the teeth that are touching. Like for example, you close your eyes, relax yourself, and see which tooth is touching in the anterior direction, and that is going to give you in the protrusion, in the lateral movement, in the protrusive movement, those are the teeth that are giving your occlusion the anterior guidance. Okay, then we go on to classifying the anterior guidance. See, you cannot classify posterior guidance because posterior guidance is provided by the temporomandibular joint, but the anterior guidance is provided by teeth. Sometimes what happens is anterior guidance is provided by canine, and sometimes the anterior guidance is provided by multiple teeth. Okay, canine guidance, hence what we call canine guidance is in dynamic occlusion, canines during an occlusion, during a lateral excursion of the mandible. This canine guidance is provided when you refer to an occlusion as canine guided occlusion, when the canines during a lateral excursion of the mandible provide the guidance. A canine protected occlusion refers to the canine guidance to the fact that the canine guidance is the only dynamic occlusal contact during this excursive movement. When you are moving the mandible, in an occlusion, and you touch the first teeth that come in contact, it is the canine, then it will be the canine guided occlusion or canine protected occlusion. So you have a non-working side and you have a working side. Non-working side is the side where you are not biting, you're not do not intend to bite with it, and the other side you intend to bite with it. See, human beings and many of the mammals, we do not bite with both the sides at one time. We bite from one side on one time at one time and the other side on the other time. But in cases, so one side will be the non-working side and the other side will be the working side. Here, for example, in this case, the non-working side, the guidance is the canine is the only tooth touching. So this side is canine guided. Whereas on the other side, see a group function where multiple teeth are touching. There in a research paper, Goldstein found that 14% of the participants whom he studied exhibited canine protection, whereas 46% had group function and 24% demonstrated a mixed type of different types of occlusion. The occlusion. See, what I want to bring to your notice is, see, one working side you can have either canine guidance or you can have a group function occlusion. Working side you can have either group canine guided or you can have a group function. If only the canine tooth is touching, then it is canine guided or canine protected occlusion, and if it is multiple teeth which are coming in contact, then it is group function. And it can be a mixture of these things in certain patients. And remember, canine guidance occlusion in patients who are aging, once the canine is worn out, generally it goes from canine guided or canine protected to group function occlusion. What we wish to have is, we wish to have a canine guided occlusion in the normal patient. But if the group function is working without any issues, then it is okay. So group function is a type of, and it's also a type of anterior guidance. The contacts are shared by several teeth on the working side during a lateral excursion, whereas in case of canine protected occlusion, it is shared only by canine. Here, in case of group function, multiple teeth are responsible for this the contact. So to qualify for the term group function, the contact would be towards the front of the mouth, and most anterior of the group would be the earliest and the hardest contact. Okay. This would contrast with a working side interference. Okay. When you are working, see, if you have an interference, the occlusal contact will be heavy and it is generally towards the back of the mouth. Once we go to the next slide, I'll show you what an interference is for you to understand. Okay, so the non-working side is the side of the mandible which is away from which the mandible is moving away. Masalan, if you are biting on the right side, the left side will be non-working side, but it is non-working, yani it is we call it non-working, but that side of the temporomandibular joint is also working. Why? It is moving away from the fossa. So if you are biting on the right side, the left side is moving towards the right side. So even the non-working side, in a sense, the mandible is moving away and the temporomandibular joint is working. Okay, now we go on to occlusal discrepancies or disharmonies, which is a very important thing which is related to, which can have an effect on the periodontium. Okay, occlusal discrepancies or disharmonies are contacts of opposing surfaces of the teeth that are not in harmony with each other or with the anatomic and physiological control of the mandible. Okay. For example, posterior interferences are considered to be a less ideal type of dynamic occlusion. Now look at this this picture which I have put in the middle. Masalan, you have something like anal gemel. in the back of your mouth. The patient is trying to close the mouth, but this tooth, which is supra-erupted or having an occlusal discrepancy, is troubling and it's not allowing the occlusion to come in proper position. So these are discrepancies. For example, you want the right side of your to occlusion to be working side. You want to bite on the right side, but when your mandible is moving towards the right side, there is a supra-erupted tooth or a cusp which is not allowing this mandible, which is locking this mandible from moving to the right side. Then this left side supra-erupted tooth or the supra-erupted or the improper positioned cusp is the occlusal discrepancy. Hope you people are understanding and following what I am saying. Okay, factors that determine a patient's reaction to an occlusion. See, occlusion is something which is normal. You have to bite on the teeth every day. You have to eat your food every day. So the teeth have to come in contact. Am I right or not? Okay, so they have to come in contact and you have to bite your dentition. But what makes this dentition troublesome for the patient, traumatic for the patient, depends on several factors. Whether the load produced by this dentition is going to damage the tissues. Okay. Normally, when you bite, masalan, you have a piece of meat in your mouth, you have a thin cartilage in your mouth, you have something hard nuts in your mouth, and you are biting. So it produces enormous amount of force. But is this force going to damage the tissues? It depends on the resistance of the tissues and the restoration. Masalan, you have a restoration, the restoration is very weak. If you bite something hard on it, it's going to break. Masalan, for example, you have temporary filling, you bite on it, the restoration will break. The magnitude of the force being applied. Masalan, you want to eat zaytun, you put the olive in your mouth, you bite it, by mistake there is a stone, the seed of the olive stone, you bite on it. So the magnitude of the force will be too high. Okay, the frequency of the force. Is this force getting repeated every time? If there is an occlusal discrepancy, even if it is small, it gets repeated every time you bite, right? The direction of the force being applied. Generally, if the force is along the vertical axis of the tooth, it causes less trouble than if it is a jiggling force. The number of the contacts that are transmitting the force. If the number of contacts are too many, then the force gets transmitted evenly. If the force is only on one or two teeth, then there is a chance that it is going to cause destruction of the periodontium. Then we go on to the traumatic occlusion. This is which is most important for from the periodontal point of view in occlusion. The rest things are what we study to understand the occlusion. But what affects us the most in periodontics is the traumatic occlusal force. It was earlier used to be called as excessive occlusal force. Now they call it as traumatic occlusal force. Excessive occlusal force is defined as the occlusal force that exceeds the reparative capacity of the periodontal attachment apparatus. Yani if you are for example, you are a young person, your body weight is 50 or 60 kilos, you can carry 20 kilos, 25 kilos. If you are made to carry 40, 50 kilos, what will happen? This will be too much of the force. Or if either your capacity, or a person is very weak, he is lifting the normal amount of weight which other people lift, still it will be too much for him. So what is there is the reparative capacity of the body. If the periodontal ligament, the alveolar bone, if it is more than the amount of the force that is being laid on it, then the tooth will manage, the tissues will manage. If it is beyond this reparative capacity, then there will be destruction of the tissues. See, occlusal trauma, I think you have already gone through it earlier, but I'm just repeating it if in case you have gone. Occlusal trauma is used to describe this injury which we were describing, resulting in tissue change within the attachment apparatus, including the periodontal ligament, the alveolar bone, and the cementum. Why does it happen? Because of result of occlusal forces. It can be classified into two types: the primary occlusal trauma and the secondary occlusal trauma. Primary occlusal trauma is because of excessive occlusal force. or traumatic occlusal force. Okay, if the force is traumatic, then you can have even the normal tissues will start getting affected. In primary occlusal trauma, the tissues are normal, but the force is excessive or traumatic. Okay, in secondary occlusal trauma, the forces are normal, or sometimes it can be extra, but generally it is normal, but the tissues are already weak. So if the tissues are weak and the force is too much, then we call it as secondary occlusal trauma. And we have something, what is this is a photograph of the of this is a description, illustrative description of the primary occlusal trauma and the secondary occlusal trauma. You can see in primary occlusal trauma the tissues are look normal, but the amount of force is excess, so the tissues are affected. Whereas in secondary occlusal trauma, the tissues are reduced, so even with normal force it can get more affected. I hope you are following the lecture. You don't have any issues. I wish that. See, now we go on to combined occlusal trauma. Combined occlusal trauma is the combination of the primary and the secondary occlusal trauma. Combined occlusal trauma is the combination of the primary and the secondary occlusal traumas. It happens in some cases where the tissues are also weak and the force is also too much. So it's like a combination of both the primary and secondary occlusal trauma. Okay, excessive and chronic occlusal forces produce adaptive physiological changes in the morphology of periodontium. Remember, this is very commonly asked in vivas, in your MCQs, in the board MCQs. All these things, these are very common things in when you come to periodontal periodontology. These are common questions that are asked. These are not strange things. They are very important. Even in viva, we always ask these questions. These are repeated things across the board. You go for any board questions, you will find these things about occlusal trauma, types of occlusal trauma, what causes occlusal trauma, what are the effects of occlusal trauma on the periodontium. These are very, very important things, and you have to understand these concepts very well. Okay. A widened V-shaped periodontal ligament. When you see an X-ray, you will find the thickening of the bone trabeculae. The bone trabeculae become thick. There is some amount of bone resorption in the gingival portion of the periodontium, and you also find the periodontal space is little bit widened. Okay, so now we go on to something what is called as fremitus. Fremitus is palpable or visible movement of the tooth under subjected occlusal forces. This is very, very important. Fremitus is a fremitus and mobility are these two things which we commonly check when we want to see the occlusal, when we want to see understand the clinical effects of occlusion. These are two things which are very commonly checked. Okay, clinically, because clinically we cannot go and do histology for a patient. So these are the available tools for us to understand if there is some issue with the. I'll go and explain it when we go on to further slides. Here we go on to the fremitus is a palpable or visible movement of the tooth when subjected to occlusal forces. Then we have to understand something what is called as bruxism or tooth grinding. Bruxism or tooth grinding. It's a habit of grinding, clenching, clamping your teeth. Okay, the force generated may damage both the tooth and the attachment apparatus. It will affect the dentition and as well as the periodontium, the tooth structure as well as the periodontium. Both of them get affected. You find the teeth which are cracks, enamel cracks in the enamel. All these things you can find with bruxism. Okay, bruxism is what you find is bruxism starts from a very early age. Generally, much of the new research shows that bruxism can be found even with very small toddlers. You can see them having this bruxism and grinding habits, and it goes on progressively increases sometimes. Okay, bruxism is classified into two distinct circadian manifestations. That is, in your day cycle, day and night cycle, bruxism is classified. When some go for sleep bruxism, they are bruxers when they sleep. For example, your mother, your sister, your brother will be telling you that, see, you were sleeping in the night and you were grinding your teeth and you were clenching your teeth. I heard the sound of you clenching your teeth.
So this is what is sleep bruxism. And some people also have a habit of wakeful or awake bruxism, and some people sleep bruxism is also called as nocturnal bruxism, and wakeful bruxism is also called as awake or diurnal bruxism. And sometimes you have bruxism which is both in the night and in the day. Okay, it is bruxism is associated with temporomandibular dysfunction. It is common with temporomandibular dysfunction. It is common with the greater incidence of occlusal interference, right? Occlusal interference, and the non-working side is troubling you when you are in excursive movements. When the mandible is in excursive movements, the some high point in the non-working site is stopping the flow of the mandible, the movement of the mandible. In cases of orofacial pain patients, see, these are all very complicated. These are all different diseases. So you have to identify them, because if you do not identify or misidentify them, the patient keeps suffering with the trouble for a longer period of time. Other possible associations are your Parkinsonism, torus mandibularis, oromandibular dystonia, Rett syndrome, Down syndrome, trauma, atypical facial pain. All of this can cause bruxism. Okay. Trauma from occlusion. Now, what we should remember is, again, we go back to our main subject, that is the trauma from occlusion and its relationship with the temporomandibular joint. See, trauma from occlusion can be definitively diagnosed only on the basis of histological change. You have to remember this. Occlusal trauma can be, how can I be 100% sure that this is occlusal trauma? The only way is histological, to see the histological report. You cannot say 100% clinically that it is trauma from occlusion. But with experience and with clinical signs and symptoms, we can assess that if this patient is having occlusal trauma. See, remember the earlier slide. In the earlier slide, we have this the clinical diagnosis. These things, the same things are again in this slide with in a box. So it's not the that I have skipped it. So the proposed clinical and radiographic indicators of occlusal trauma are fremitus, tooth mobility, especially progressive tooth mobility, occlusal discrepancies, wear facets. Wear facets is like part of the tooth structure is worn out. See, all the people, when as the age progresses, you feel some amount of tooth wear, because, like, for example, central incisor erupts when a patient is 6 years of age. The mandibular first molar erupts when a patient is around 6 years of age. Now you get the patient, see the patient when he's 50 years of age. You cannot find a patient who has used his tooth for around 50 years of age, 54 years of age, badal eruption, that there is no tooth wear. 100% same like with mammalians. Of course, it will not be there. But what we see with wear facets is that there is excessive wear of the tooth structure, tooth migration, fractured teeth. Seventh is tooth thermal sensitivity. Patient complaints of pain when he or she is drinking hot water, cold water. Thermal sensitivity, discomfort, pain on chewing, widened periodontal ligament space, root resorptions, and cemental tears. All of them are very, very important things that we should take care. These are clinical and radiographic indicators of occlusal trauma. It's a very important thing when it is coming to periodontics. Now we go on to the occlusal effect of occlusal force on the periodontium. You can see the inadequate occlusal force can cause atrophy. For example, if you have a tooth which is extracted, the opposing tooth will not be grinding anything, it will not be functioning, so there is chance of atrophy. In a physiologic healthy tooth, there is a stability between the force and the tissues. There is some amount of force and there is repair, regeneration going on hand to hand. Okay, but when the tissue becomes weak, the ability goes off, there is injury, or if the force is too much, there can be injury and the destruction of the tissues. Okay, requirements for occlusal stability. What do we require? How do we consider the occlusion to be stable? When the forces on an individual tooth do not exceed the support and resistance. That is, there is no traumatic occlusal force, and it is not beyond the capacity. And the occlusal force is in the long axis of the tooth. And what we want is, we want the teeth to have, posterior teeth to have contact, simultaneous contact, when in maximum intercuspation. In centric occlusion, we want the teeth to have multiple simultaneous contact. Okay, little or no contact in the anterior teeth in centric occlusion. We do not want anterior teeth to be in contact in centric occlusion. Why? Because every time if the anterior teeth are in contact, they are single rooted, they will be affected more. Okay, and harmonious exclusive and movements. When the mandible is moving, the movement should be harmonious. That is, there should not be an occlusal interference. The tooth should not stop it from moving. Okay, now we go on to the temporomandibular disorder screening evaluation. See, these are things that you also study in oral pathology. You study this in oral medicine. Here we are going to study it, to read it, to go through it fast in relation to periodontal disease, not in relation to the exact oral medicine, the oral pathology thing. We are going to study it in relation, not as not the individual temporomandibular disorders and dysfunctions and diseases, rather the effect of these disorders on the periodontium. Maximum intercuspal opening is 40 to 50 millimeters. We want the opening and closing pathway to be smooth without any discrepancy. We want the range of protrusive and extrusive movements to be 7 to 9 millimeters. We do not want the sounds to be there in the TMJ joint when it is opening. When you palpate, we do not want the pain, tenderness. The muscles should not be tender, and the loading test of the patient's temporomandibular joint should be fine. Hope it is clear. Okay. A thorough examination of the temporomandibular. When you want to check the occlusion, you want to go for a thorough examination of TMJ, temporomandibular joint. You know how to stand, where to stand, you with the patient, how you have to put to palpate the temporomandibular joint. Hope you all do this in clinics. Okay. Temporomandibular deviation, we have to be presence in opening. And see, the degree of mandibular opening should be determined by measuring the interincisal distance, the distance between the two incisors. It should not be less than 35 millimeters. 35 millimeters. If it is less than 35 millimeters, then Manatha, the opening is restricted. Okay, the degree of movement upon, and okay, when you move the mandible, it should be normal is around 12 millimeters, accepted when it is lateral movements. See, you palpate the masticatory muscles with your extraorally and intraorally with a finger, thumb and finger, and you palpate the muscles, especially in places of insertion of the muscles, because generally when you have muscle issues with the orofacial pains, different syndromes, the place of insertion of the muscles, patient will have pain. Okay, so you have to know the muscles of mastication. You have to know their I hope you know the muscles of mastication, inshallah, the muscles of mastication and the places where they insert, and you have to check for tenderness. Make a note of appearance of the face. See, faces shapes are different. Face, long face, dolichocephalic, square shaped face, brachycephalic, and you have mesocephalic, the oval shaped face. That's what, in simple ways, the shape of the face. People who have brachycephalic face or square shaped profile can have a chances of having hypertrophy of muscles, and they can have clenching of the teeth habit. So this you have to be careful, and you have to be looking for patients with square shaped profiles and square shaped faces. The static occlusal examination, you check for tooth rotation, crowding, overbite, spacing, all these things, and you will check for freeway occlusal vertical height or freeway space. What is freeway space assessment? You will ask the patient in the resting vertical dimension. Ask the patient to relax, keep his face straight, moisten his lips, and check the resting vertical dimension. Then you ask the patient to close his mouth, and you will check the occlusal vertical dimension, and you will see if there is any discrepancy, a certain Okay, and make a note of this OVD. OVD is occlusal vertical dimension, and how much the patient can relax and whether this freeway space is adequate. This is very important, especially when you do restorations, because if you are going to impinge on the freeway space, then there will be patient will get issues with the closure and opening. You will check for dynamic occlusal examination. You will check for retruded contact positions. Retruded contact positions is when you will check the centric relationship, which refers to the maxillary and the mandibular relationship, where the condyles are located in the most anterior superior position in the glenoid fossa. That is, they are at in simple ways, they are at the backmost position. At vara yani at the back position. So you will check for retruded contact position, the RCPs. You will check for the terminal hinge axis. The arc of closure occurs at the arc of closure. See, these are all terms you have already done with your I hope you have done this in prosto with your when you are checking the occlusion of the patients for making. So but this is a repetition to make you refresh this. Then you will check for you have to document the patient's anterior guidance. How will you document a patient's anterior guidance? You will ask the patient to close his mouth in maximum intercuspation with light occlusal contacts should be present in the anterior teeth. What we earlier said is we do not want very tough contacts in the anterior. We want simultaneous contacts in the posterior, and we want very light occlusal contacts in the anterior position. So if you are making a restoration, especially for the maxillary teeth, you do not make the restoration too thick in the palatal portion. If you make it too thick in the palatal portion, then you are going to hinder the normal anterior guidance. Make a note of the presence of any occlusal interference. It is very, very important in relation to undesirable to periodontal status of the dentition. Undesirable contacts that occur between opposing teeth in the mandibular position. These are very, very important, especially in lateral excursions in the non-working side. If the non-working side is pulling your mandible and it's not allowing its free movement, then you have to take into consideration that, and you have to treat it. See, then you have to check for the mobility of the tooth. Checking the mobility of tooth is very, very important. You know the already you have done your perio chartings, and I hope you have done it, and you know the grades of perio of the mobile tooth, the Miller's grade, the how you grade the mobility of the teeth. Now, when it comes to periodontal therapy, in non-periodontitis patient, if there is occlusal treatment to improve, if there is mobility, then you have to, especially the class 2 and class 3 mobility, you have to go for non-periodontal patient, you have to go for occlusal treatment. You see, improve the comfort of the patient and the function of the dentition. And once it is done, you have to monitor the stability. Check the patient when he comes for your recall if this is stable or not. In cases of periodontitis patient, remember that in cases of periodontitis patient, you have to go for phase 1 therapy. You have to reduce the inflammation. You have to go for non-surgical periodontal therapy. You have to reduce the inflammation. You have to remove the cause, the plaque, the calculus, and then once the inflammation is gone, then you have to think of occlusal treatment. You should not jump for occlusal treatment before you go for the reduction of inflammation. If after reduction of inflammation, after your phase 1 therapy, if there is the mobility reduces, then you need not go for occlusal treatment. You can go for occlusal splints. If there is remaining occlusal mobility after post orthodontic treatment and the patient feels discomfortable, or you can, if there is increasing mobility, again you can go for other treatment options, the occlusal treatment options. But first, in cases of periodontitis patient, you have to reduce the inflammation, you have to remove the plaque and calculus. Okay, and then you have to recheck for your tooth mobility, because sometimes with inflammation it shows the mobility you will find it is more, but once you go for you remove the plaque and calculus, and you reduce the inflammation, the mobility reduces. So it is optimal resolution of inflammation is necessary to accurately interpret tooth mobility. So remember this very well. Okay, now if you have these occlusal issues, you go for an appliance therapy. What is an appliance therapy? You go give a night guard. You give a night guard. See, night guards, we always make night guards with hard acrylic. We do not make it with soft acrylic. See, normally we have a and the and the night guards should not be active appliance. They should be passive appliance. They should not be changing the position of the teeth. What I mean to say, they should be passive appliance. They should not have. They should be smooth. They should be clean, and they should be, you once you make it for the patient, you make more than one for the patient. Ask the patient to wear in the night. See, the advantage of this appliance therapy is it is removable, it is reversible. If it doesn't cause permanent change to the occlusal surface. But the disadvantage of the appliance therapy is if the patient is not compliant, low marid ma yalbas, if he's not wearing it properly, he's not wearing this appliance properly, then it's not going to help the patient. But the advantage is it is reversible. So you need not remove the tooth surface, you did not do the grinding. If the appliance therapy is working well with the patient, it's okay. Otherwise, some patients you need to go for occlusal adjustment, especially with interferences. You have to reshape the surface of the tooth. See, remember, occlusal adjustment is a permanent irreversible treatment. So you will not do it in the beginning. You will do it after removing the plaque, calculus, after reduction of the inflammation. If the patient is not able to manage this with appliance therapy, then you will go for occlusal adjustment. Okay. And when you do occlusal adjustment, you have to keep yourself within the limits of the enamel. Don't jump and remove the dentin and cut the tooth black and blue. Be very careful. And it is always advisable to start with occlusal to do the occlusal adjustment in the last, not in the first, after your phase ones and all those things. And you do it in the supervision of a person who is experienced in doing occlusal adjustments. Okay. Then we go on for the indications. Occlusal adjustments is, you always do it when you need an restorative treatment in cases of trauma, jaw trauma, all those things. When the patient has parafunctional habits, sometimes you need to go for this occlusal adjustment or selective, what you call it, selective grinding. Traumatic injuries, in cases of traumatic injuries, you need to do. In cases of progressive mobility, this is very, very important. Increased mobility or progressive mobility. Manatha, you check the patient today, you check the patient after 10 weeks or 12 weeks, you find the mobility is increased. If you see this mobility increasing and your treatment, you are doing all the treatment, available treatment, and the mobility is still increasing, then you go for it is an indication for occlusal adjustment. Contraindications is you should not do it as prophylactic treatment. Some people get any dentition and start trying to do occlusal adjustment. You should not do it. Severe extrusion of the malpositioned tooth, you have to do root canal treatment, and you have to give a crown, or you have to go for extraction. You will not go for just grinding of the tooth. Primary treatment for bruxism, do not jump in cases of bruxers and start doing occlusal grinding. It is better to go with appliance therapy. It is de-stressing, counseling of the patient, helping him remove his stress, cope with the stress, rather than going with the treatment of with occlusal grinding. Emotional state of the patient is not satisfactory, then do not touch the patient for occlusal grinding. Okay, occlusal adjustment is necessary when the RCP and ICP, the maximum intercuspal position and the retruded cuspal position, if the difference slide is more than 1 millimeter, then in such cases, when this is present, this is one of the things that indicates that there is an adjustment is necessary. See, you will check the RCP, the retruded contact position, and then you will see the ICP, the intercuspal position. If the difference is more than 1 millimeter, then and the patient is also having temporomandibular joint pain dysfunction syndrome, he's having bruxism, in such patients, or you want to do the oral rehabilitation, you want to do full mouth rehab, you want to give a lot of crowns and fillings and cosmetic and aesthetic things, then in such cases it's recommended that you go for occlusal grinding. Okay. Sometimes you also go for tooth splinting. Tooth splinting is again a simple treatment, but what we have come to know is that this splinting does not improve the survival of the mobile teeth. See, it's similar to the splint what they give post orthodontic treatment. You can give a removable splint, you can give a splint with the composite and wire if there is mobility for. See, these things are given only to improve the comfort of the patient, but it does not improve the survivability or of the tooth, longevity of the tooth. It does not improve, especially in cases of advanced periodontitis. That's what the newer research says. Okay. An occlusal adjustment on teeth with mobility or premature contact may lead to improved clinical attachment level. So if you have progressive mobility or if you have premature contacts, that you have occlusal discrepancies, then you have to do occlusal adjustment. But you have to check this tooth mobility after you do your non-surgical periodontal therapy. Then tooth mobility, as I had told earlier, we'll go for tooth mobility and fremitus test, or see the difference between this is normally we ask in Viva, what is the difference between tooth mobility and what is the difference between fremitus? So you have to put your effort on it. These are two important clinical things which we do, tests which we do. You know how to do tooth mobility test with your finger and an instrument, or with newer specialized instruments you can check the tooth mobility. Fremitus is again palpable functional mobility. The difference between tooth mobility, checking the tooth mobility, and the fremitus is, in cases of fremitus, you make the patient go for to bite his teeth. That is, he occludes his dentition, and you keep your finger on the surface of the tooth and check if there is vibration. See, you have to you have to train yourself to go for this feeling, how you feel this. With after a few times you can surely understand that if there is fremitus, there is functional mobility in the tooth or not. Whereas in cases of tooth mobility, you do it with your instrument and your finger, or with two instruments. So tooth mobility, the force, you are generating the force, whereas to check the fremitus, you are making the patient bite and to create the vibration if he's having it. So palpable functional mobility of the tooth is fremitus, whereas the tooth mobility is what tooth mobility is. See, both of these are clinical signs with which we know, both fremitus and tooth mobility are clinical signs with which we know whether if the occlusal scheme is having an effect on the periodontium, and we can know. See, you can have occlused tooth mobility because of just periodontal causes, and sometimes the occlusal trauma is not the primary or the sole cause of periodontal problem. But occlusal trauma, it influences the progression of the periodontitis, especially tooth specific. Some teeth are affected by the occlusal trauma, and the periodontitis, or the inflammation, it progresses rapidly. So in such cases, we have to be very careful. Occlusal trauma can amplify. Remember very clearly, occlusal trauma doesn't cause disease. You need plaque, you need calculus, you need the inflammation, you need the destruction of the tissues. But if there is occlusal trauma, it increases localized loss of attachment is from inflammatory occlusal bone damage is increased. It can amplify it, it can increase the destruction, the progression of periodontitis, but it doesn't cause. An inflamed periodontium often contributes to the mobility of the tooth. So you have to remove the inflammation to check the exact mobility of the teeth, the optimal mobility of the teeth. Optimal resolution of the inflammation is necessary to accurately interpret tooth mobility. These are very important facts which we use clinically every day and every time when we check the patient. Again, we go on to the conclusion of this occlusal treatment and occlusion in relation to the temporomandibular DCT dysfunction and diseases and all the conditions. See, what we do is, see, the entire conclusion, you can put it in three things. First, go for anti-inflammatory therapy. What is anti-inflammatory therapy? Remove the plaque, remove the calculus, reduce the inflammation, ask the patient to brush his teeth properly. All this will be your anti-inflammatory. Your basket is full of anti-inflammatory things. You can go for scaling. You can go for the patient for plaque removal. You can go the brushing techniques. You all these things to remove the plaque. You in cases of stage 3 periodontitis, rapidly stage 3 grade grade C periodontitis, you will go for antibiotics. All these things are your arsenal of anti-inflammatory options. Then you go for reversible appliance therapy. After all these things, if there is still occlusal issue, go with a reversible appliance therapy. What is reversible appliance therapy? Your night guards and all those things which are reversible. Still, if there is the things are not improving, go for selective grinding or your splinting, selective grinding. All these things you can go when for irreversible options, when the reversible options do not function in a patient. I hope you understood the lecture. You have any issues with understanding, you have this downloaded, this PowerPoint I have given you, as well as this lecture. You have any problem with understanding it, you can bring the lecture and we can discuss it. Hope this will be an enjoyable session for you, and inshallah you will be understanding it. And thank you for being with me, bearing with me. Thank you.